absolutely wonderful for the James Mackenzie Lecture, Carolyn Chew-Graham. And I'm just so pleased because I've known Caroline for many, many years, mainly in her research around mentally ill doctors, which has actually been groundbreaking work, and I think won one of the college's papers of the year around GPs and their mental illness, but also because of the amazing work that Caroline has done in the care of the elderly, and just amazing work that she's done around primary care. Now, I'm going to read a bit about what she is, otherwise it'll be remiss about me. So she's Professor of General Practice, Research at Keele University. She's Honorary Professor of Primary Care Mental Health at Midlands Partnership University. She's Honorary Professor of Primary Care at the University of Manchester. And you're also a visiting professor if you haven't got enough professorships at Keele University. She's also a GP principal in Manchester, and I know continues to work very, very hard with her patients. She's a former chair of the Society of Academic Primary Care and the former chair of the FRCGP Scientific Foundation Board. She currently chairs the RCG Research Paper of the Year. She's got experience running NICE guidelines, including the guidelines on group discussions, depression, and she's also had involvement in guidelines on patient care and commissioning. She's editor-in-chief of Health Expectations, and I'm delighted, absolutely delighted, that she recently got an OBE in the King's Birthday Honours, so thank you. And she got it predominantly for her work in general practice, but also for her work in long COVID. Her research focuses on primary care management of people with anxiety, depression, multiple health conditions, and unexplained symptoms. She is a star, and I would actually say she is probably one of the best academic GPs currently in this country, so I'd just like us to thank Caroline. Here is your medal. Well done. You don't have to open it now.
That was an amazing introduction, Claire. Thank you so much. Okay, President, Chair, Fellows, members, colleagues, many thanks for inviting me to give this prestigious lecture. I'm honoured, but I'm really scared as well, so be gentle with me. I'm going to put my glasses on so I can actually read what I'm going to talk about. So I'm going to talk about the importance of listening. James Mackenzie was a visionary Scottish general practitioner who received international acclaim for his research into the rhythms of the heart. But he also firmly believed in the importance of basing medical education in the community, the value of observation of his patients, and the value of listening to his patients, observing them and understanding them. Tom Fahey spoke in his James Mackenzie Lecture in 2019 about the hierarchy of evidence which has evolved since Mackenzie's time. Tom focused on the importance of randomised controlled trials, which are considered the gold standard. But I'm going to talk about the value of listening to patients, and if I can just get that down, and the value of qualitative research, which I believe can be as impactful and can contribute to the evidence base which guides our practice. So I've got a technical problem here with the slides. Don't know if I've pressed something. Oh, I think it's moved twice. So, acknowledgements. Please forgive me if I've forgotten anybody. So I want to acknowledge lots of people. Carl May, who is my thesis, my PhD, my MD supervisor, Carl Whitehouse, who was my GP trainee, and David Ratcliffe, who was a partner in general practice when I first started in my current practice, Chorlton Family Practice in Manchester. But I want to thank all the teams I've worked with, and I want to thank my family. There's a little picture of them there. They've been immensely supportive, and I do realise that I probably neglected my son and daughter when they were young, and I apologise. So I'm going to talk about listening. I'm going to talk about qualitative research methods, as I've said, but I'm also going to talk about listening to patients in consultations and listening to colleagues, particularly in practice teams. And I'm going to mention the importance of listening to people with lived experience who have become partners in our research teams. I'm going to try and talk about the impact of some of the qualitative work that I've done, and I'm also going to pose some questions relating to the future of general practice that we can mull over dinner. And I want to reflect on our motto, science with compassion. And I think compassion includes listening. It includes empathy, demonstrating empathy and understanding within our consultations. And that brings me to the consultation. I still believe that the consultation is the cornerstone of general practice. As James Spence, who was a paediatrician, said, the essential unit of medical practice is the occasion when, in the intimacy of the consulting room or sick room, a person who is ill or believes himself to be ill seeks the advice of a doctor whom he trusts. This is the consultation, and all else in the practice of medicine follows from it. I've spent much of my academic career talking with patients and practitioners about the consultation and hopefully using this work to improve patient care and to support primary care clinicians in managing patients. When I first qualified as a GP, I had shorter hair, but I was stunned at how powerless I felt in the face of the problems that my patients in inner city Manchester disclosed. I'd not been exposed previously to the poverty, the pressures people faced in their daily lives, the inequalities, and then the added impact of symptoms and illnesses. I'm sure those feelings account for the direction both my clinical and my academic careers followed, and I still work in central Manchester. What I came to realise as a new GP was that people presented their feelings, their needs, their problems, and that I as a GP had to listen to them, to hear people's concerns, to help people make sense of things, and then to try and help that person move forward. And that wasn't necessarily resulting in a diagnosis, but it was a shared management plan. My good friend David Shiers introduced me to the concept of general practice as a swamp. In the varied topography of professional practice, there's a high, hard ground of technical rationality, randomised controlled trials, which overlooks a swamp where problems are messy, confusing, and sometimes incapable of technical solution. The difficulty is that the problems of the high ground, however great their technical interest, are often relatively unimportant to clients or to the larger society, while in the swamp are the problems of the greatest human concern. And it's in that swamp that we as GPs work. I'm a swamp worker. My patients are part of this swamp. I try to respond to my patients with compassion, and listening is part of that. I use this analogy of a swamp with GP trainees in our practice to help them try to make sense of the multiple problems that they may be confronted with in a short consultation and what their role involves. As an academic, I've tried to tidy up the swamp for my colleagues, hopefully contributing to the evidence base which underpins our work, bringing science to individual consultations, to patient management and to commissioning. I couldn't give the James Mackenzie Lecture without talking about the models of the consultation that underpin my work over the last 30 years. I talked with trainees about the importance of these models, about how we can use them to make meaning out of what patients bring to us, but how listening is key to helping us make that meaning. I want to reflect on one patient I saw recently to illustrate the importance of listening as the patient discloses details of their own swamp. Mahina came in, never met her before, to a face-to-face appointment accompanied by her son. This was 4 weeks ago. Her main complaints at that time were cough, pains all over, tired all the time, a bit of weight loss. And at the end of the consultation, after which I'd tried to take a full history, examine her, I'd organised quite a few investigations, and I booked a follow-up appointment with me. She'd seemed cheerful at the end of the consultation. She was joking with her son about their shared concerns. She came back last Monday and said that her other son had dropped her off and he'd pick her up. He didn't like coming to GPs with her. She told me how lucky she was to have 3 wonderful sons. She followed my agenda. I went through all her normal results. I inquired how she was feeling. And at this point, she became tearful. She disclosed that her 14-year-old grandson had been discharged from hospital. His parents had been told there was nothing they could do. He'd got some sort of genetic condition. She didn't know what this was, but he was now confined to bed. He was on morphine. She disclosed that some people in her community put the blame at her son's door, and this bothered her. I asked her if she was depressed. She said no, she wasn't depressed. She'd got some good friends. She had a good support within her community despite the difficulties. I asked how I could help, and she said, it's just been helpful to tell someone. I'm going now, and my son will pick me up. As she got up, I got up and opened the door, and she hugged me, and that meant a lot. And I think I've established a relationship with her, and she'll come back and see me, and that's what's important in general practice. We get feedback in other ways. As part of revalidation, I'm sure people are aware that we give surveys to patients to ask them to score our care. This took quite a lot of effort this year because half my consultations with routine consultations are on the phone. So a lot of my surveys were given out to people on the day appointments. But as I was popping the completed questionnaires in the envelope, I noticed this comment in the free text. I've known Dr. Chew-Graham for many years. She's always been there for me. She listens and cares. So again, the importance of personal continuity, of personal relationships, and of listening is evidenced. But the consultation is changing. Our consultations are now structured by protocols and tick boxes, particularly as part of the quality and outcomes framework. And here is where my clinical and academic work overlap, where research questions are driven by reflections on my clinical work. So I conducted a qualitative study with a team with observations of long-term condition review consultations. And we showed that review consultations shape patients' expectations of future care. They socialise patients into becoming passive recipients of surveillance. Patients' needs outside the narrow protocol of the review are made invisible by the process of the review, except in really extreme cases such as anticipating death and bereavement. We made some suggestions about how the constraints we demonstrated could be overcome by clinicians, being aware that patients have a lot more to do than the biomedical work associated with their long-term condition. We suggested that consideration is needed of how we can acknowledge and support people in the broader aspects of their lives, cognizant of the multiple problems people have, again back to the swamp. And we suggested that GPs needed to facilitate and encourage patients to bring their concerns, their own agenda, to the consultation and offer continuity of care. This work was done over 10 years ago, and I don't think things have changed, and I think perhaps we need to look at our suggestions even more now. Because what's happening? What's the future? Policy directives and the COVID pandemic pushed remote consulting. Video consultations haven't really taken off, but we are doing a lot of work on the telephone. In my practice, the requirement for us to respond to online queries on the day has forced us to prioritise urgent care. We've expanded our clinical team. But the result is that some groups of people, those who are less digitally or health literate, those who are not fluent in English, those who don't have a smartphone or access to the internet, find real difficulty getting their voices heard. And as I work down the online queries when I'm duty doctor, I reflect that I've lost the opportunity to listen to people. I can't listen to what their concerns really are, but I have to make a judgment on a couple of sentences which might say, abdominal pain 2 weeks, knee pain and swelling, sore lips. So, how do we, in our practices, listen and support each other? Practices are getting bigger. When I joined my practice 22 years ago, there was myself and my partner David, and we had 2,000 patients, and we knew our patients. I'm now in a practice following multiple mergers of 24,000 patients, broader and expanded practice team, and I don't know how many doctors there are. We have a practice WhatsApp group that offers informal support. We have more formal team meetings where we do endeavour to listen to each other, but often that's crowded out by the need to make decisions. We've got the new wellbeing points in QOF. That's encouraged my practice to think about more regular nights out. We provide croissants on a Monday and pizza on a Friday. I'm not quite sure that fits the bill for wellbeing. Staff like it. It doesn't help us listen and share with each other. And outside the practice, some people have first five or balance groups, but often we don't have the opportunity to really listen and share with each other. Is that better?
Yes.
Sorry, it keeps slipping. So, where else does listening take place? I work in a 1980s health centre, brick walls on the inside. We have no facility to sit down and have lunch. We eat lunch at our desk. So the kitchen is where we talk and share. We can squeeze 4 people in if we ignore the sign on the floor that says we must maintain social distancing. And it also takes place in our consultation rooms. Sometimes this chair's occupied by a colleague who just needs to talk, the duty doctor who feels overwhelmed by the volume of online queries, the nurse practitioner who's coping with caring for her mother, and the staff member who was shouted at by a patient whose prescription wasn't ready. But what of the future of general practice? We have increasing demand, we have packed days, we often don't have time to stand in the kitchen and talk or to keep our door open for the person who needs to come in. We've got rising expectations. We're criticised for being part-time. Some practices have difficulty recruiting GPs. I think consultations are transactional. We're providing fragmented care rather than good continuity, and the media coverage over the last 2 years hasn't helped. So, something for debate. I still firmly believe in general practice. Now I'm going to move on to the bulk of my lecture this evening, and I want to reflect on the importance of qualitative work. And I feel I have to defend this research method from an accusation said to me many years ago that my research was fluffy. It's not fluffy. So, qualitative methods purport to investigate the how and the why. Methods include observations of, say, consultations or clinical encounters, and interviews with patients or clinicians. And the data generated is analysed to give us meaning. We interpret that data and we build models and explanations. Some early work I conducted with Carl May demonstrated the importance of considering the role of the qualitative researcher, particularly when that interviewer is a GP interviewing another GP. We described 4 possible roles that the GP interviewer could be perceived to be by the GP participant. One of the GPs, I remember, said, he was firmly thinking of me as a judge, God, I hope you're not from the Daily Mail. So we need to consider, when we're conducting qualitative research, what role that interviewer has in the generation of data. And thinking about impact, the concept of reflexivity is now widely used in qualitative research, and this paper is highly cited. I mentioned earlier that I always try and link my clinical and my academic work. I try to ensure that research questions are generated from clinical encounters or problems I'm encountering as a primary care physician, as a GP. And one of the first research areas I focused on was back pain, because I really struggled with, as a new GP, managing people with back pain. I felt they went away from the consultation not very happy, and I certainly didn't feel that my consultations were satisfactory. So I worked at the Robert Derbyshire practice in central Manchester, and we secured funding to set up a clinic offering acupuncture and psychological support to people with persistent back pain, and I embedded a qualitative study within the clinic. And what did patients say? They described lack of continuity of care and different explanations from different doctors. And they described not really being believed or listened to. I moved on to interview GPs. And my data illustrated how frustrated GPs were. Medical training emphasises the importance of diagnosis as the first step in the management of real pathology, a biomedical approach. Where this step cannot be taken by the doctor, the diagnosis is in doubt, the label or explanation has to be negotiated between the doctor and the patient. And GPs struggled with this. So they illustrated the same sort of frustrations and discomfort with back pain consultations that I was experiencing. I was going to put impact on this slide, but I'm not sure that that early work has really made any impact in the formal sense, but it has certainly led to a strand of my work that's focused on unexplained or persistent physical symptoms, which I continue today. I mentioned that qualitative findings can be described in a model, and this is a model of an analysis of qualitative work around chronic fatigue syndrome. A group of us looked at a number of qualitative studies around the support that people with chronic fatigue syndrome needed, and we developed a model. You might think, why is she showing me this about chronic fatigue syndrome? So I presented this at a School for Primary Care Research patient and public involvement meeting. And I summarised the findings by saying people with chronic fatigue syndrome, ME, want to be listened to, they want to be believed, they want to have positive relationships with everybody around them, and they want to work in partnership with healthcare professionals to find solutions. A patient on the webinar said, I fully support your findings of fraught clinical encounters and the need for care focused on relationships. Thank you for reflecting the voices of patients in academia this way. So feedback from patients was very positive and is crucial to the work that we do. And we talk about patient and public involvement and engagement, and this has gained traction over the last 20 years. This entails research being carried out with or by members of the public rather than to, about or for them. And my work with the journal Health Expectations has really brought patient and public involvement to the fore. It's a prerequisite of all papers submitted there that they include that section in the abstract. So the value of patient and public involvement in all our work is illustrated by this webinar that was held at the beginning of the year. We had some work with a quantitative database, and we had a very strong young people, parents and carers advisory group led by McPinn. We held a webinar which I co-chaired with a young person, and these were their voices. We sometimes feel invisible, we want to be empowered. So this illustrates the importance of patient and public involvement in our work. But I'm going to go back 20 years, because another thing that perplexed me as a new GP, or less than new GP, was why is depression underdiagnosed and undertreated in older adults? So, conducted a qualitative study with older adults and primary care practitioners to try and find out why. And older adults said, well, it was my worries, it was the stress, felt a bit run down. It was my leg, then the robbery. But clinicians talked about the fact that they felt we were medicalising the discontent of people in inner city Manchester, or medicalising feelings that were justifiable, because if you lived in that situation, if you've got multiple long-term conditions, you would feel depressed. So we coined the terms normalisation of depression, reflecting how when older adults and clinicians felt there was an explanation for low mood or depression, then nothing should be done. and therapeutic nihilism to reflect the feeling that nothing could be done. And that this is a salient paper, which is again highly cited in our work, the work that I continue to do with older adults, but also people around the UK who work on improving the mental health of older adults. And this work has had some impact as well as being a foundation for other work. So clinician training, policy documents, NICE guidance, and work with Age UK, and work with the FRCGP. So we developed some top tips for the diagnosis and management of common mental health problems in older people. And I've just worked with NHS England to produce some online learning modules for a range of health and social care professionals around identification and management of depression and anxiety in older people. And the most current work that I've been doing is looking to see whether actually non-traditional providers, alternative providers, non-NHS, could support the detection and signposting for mental health problems in older adults. So we've worked with North Staff's fire service, done lots of listening in focus groups and interviews, and observation of home safe and well visits, where we think that fire and rescue service personnel could ask about low mood, stress, anxiety, loneliness. And as outputs, we've developed a training package for fire and rescue service staff and a video for older adults. Another question, again, going back 12 years, was we've got people, increasing number of people in our consultations who've got multiple long-term conditions, particularly mental and physical comorbidity. So again, conducted a qualitative study, and this was a highly cited article, and I'm going to move on to the patient voices. If I do go and see him, it's usually about something else. It's not about the depression. To be honest, I've not really told him. And another service user who says it's the stigma that's attached to the psychological aspects. So people talked about how they prioritise their physical health against the stigma, and again the stigma of disclosing mental health emerged. Particularly proud of this paper because it was a winner of the mental health category Research Paper of the Year in 2011. Gosh, that's a long time ago. And on my right was Helen Lester, who sadly died in 2013, and she was an inspiration to all academic GPs. We were all in awe of her. And again, just briefly mentioning the impact. Quite a lot of clinician training came out of that work. We worked with IAPT, the Improving Access to Psychological Therapies, policy documents, NICE guidelines, and we worked with a group of charities to develop some guidebooks for clinicians in primary and social care about how to manage people with multiple long-term conditions. Fast forward to 2020 and a study that I am particularly proud of, so I'm going to spend a little bit of time talking about this. Started with listening to people registered for my practice saying that they hadn't really recovered from an acute infection of COVID-19, a presumed infection because there was no testing. And then listening to colleagues looking at social media. Started to think, what's going on? So I very quickly got ethical approval to conduct a qualitative study interviewing people who were continuing to experience ongoing symptoms following an acute infection with COVID-19. Had a lot of patient and public involvement in this work, linked in with long COVID support, UK doctors long COVID. I still work with the Manchester COVID-19 peer support group. And we published this paper in October 2020. And I think it was the first paper that was published reporting narratives of people with long COVID, as it had come to be called over the summer. And our findings are listed here, and I'm going to present some data. So, people talked about the hard and heavy work of managing their symptoms, I have to pace myself, I have to do a chore, sit down for 20 minutes and then do the next one. Frustrates me. And people also talked about the difficulty accessing care. And as a GP, I found listening to those narratives particularly hard to hear, because people, on the whole, talked about negative experiences, trying to access their GP, trying to talk to the GP, being believed. People talked about how they were living with uncertainty. This is a new virus. What's going to happen? Is it going to reactivate? And we know that some of those fears have been realised. Participants talked about the need to find the right GP. I think I might be on the wrong... There we go. So participant 18 said she listens just a little bit more to what I'm saying. She's much more willing to say, of course we don't know what's going on because it's a new disease. Being listened to came out really strongly in the narratives. And people talked about the need to have multidisciplinary assessment, face-to-face consultations with somebody because they weren't getting them from their GP. So, impact. Nice guidance. We appeared in the nice guidance. And actually this paper and some of the field notes and descriptions that I submitted to the NICE committee were really replicated. Believe your patient, listen, acknowledge their symptoms and problems, show empathy. That's not just about long COVID, is it? That's about sitting with a patient in a consultation. Do not dismiss this as a psychological problem. The participants in my study had said, I've just been told I've got anxiety, but I haven't, this is real. And NICE talked about the need for shared decision making. Other impacts were some top tips that we developed fairly quickly for FRCGP and a learning module, and quite a few articles in, say, BJGP Life and other journals. I want to move back to listening to colleagues. I want to illustrate the value of qualitative studies in describing the pressures that all our colleagues are under. So this study was a qualitative study conducted by a medical student back in Manchester 20 years ago. This was a research option, and the student managed to do 22 interviews in about 6 weeks. There was no iterative approach to her analysis, but we'll forgive her because she produced fantastic data. And the key thing was, I wouldn't want it on my CV or their records. The stigma around mental health in medical students was there for all to see. Have things changed? And how are my colleagues doing now? Claire kindly mentioned the work that I was involved in with a team around distress and stress in general practitioners. We were funded by the School for Primary Care Research. We conducted interviews with about 42 GPs. We described the sources of stress and distress. So this male GP said, I think when you're dealing with really difficult problems, you're dealing with lots of sadness. You're dealing with loads of stuff that you can't change, and people bring in and park with you their problems and their sadnesses. They feel better and you feel worse. And that reflects how I felt 30 years ago. We also talked about the barriers and facilitators and survival strategies for GPs. So this GP said, never mind reflective practice and balance groups and all of this. People are just, nose to the grindstone absolutely all the time. And this GP was a male on sick leave and said, I've been very lucky with the GPs I've seen over this problem. They've been understanding and sympathetic, which is what we all should aim to be. More recent work has focused on the question about supporting colleagues bereaved by suicide. This happens in the NHS. And we conducted a qualitative study, and we've developed guidance and a training package that we hope will be rolled out across the NHS and in general practice, so that we have a response that is based on the evidence we've generated. So this quote was from participant 9. And my manager said, I want you all to go into the office. I need you as a team to be together. So we did. We all got together and just sat and laughed and cried and laughed and cried. And it was nice to be together, to support one another. And so we've developed some postvention guidance. As I say, we hope that this is going to be rolled out across the NHS, including general practice. Too early for impact yet. In summary, what's the value of listening? In the consultation, patients need to feel they're believed and heard. We must demonstrate that we've got the time and that we want to listen and that we have listened. This will facilitate patient-centred care, which is what we should be striving for. Being available to listen within our practices is key, and in other teams we work in my research teams, trying to create a supportive environment, trying to develop trusting relationships. Listening to people with lived experience as partners in research teams enhances the quality of our research. And finally, qualitative research can impact on individual patient care, on guidelines, on policy, and contribute to patient education. Many thanks for listening to me, and thank you again for the honour of delivering the James Mackenzie Lecture.
You see what I mean? She captured the role of the GP in getting down in the swampy lowlands with our patients. But actually, more than that, this woman has been groundbreaking in doing fluffy research. No way is it fluffy. And I've had the honour of being part of her research team, and it certainly changed my practice. And I think that she is such a wonderful gem in our profession. And I'd just like to thank you. You are a wonderful human being. And, we now learn listening. And, of course, listening is so vital. But you've taken listening to the science of listening. So thank you so much, Caroline.
Thank you.
OK, ladies and gentlemen. Some of you are going to get dressed this evening. But can I thank you? And I think there's some small drinks out on the bridge. But thank you so much for coming, and thank you online for listening. And take care.